Good morning, everyone. It's nice to see you guys so bright and early today. I know we still have a few people filing in, so we were just waiting a couple of minutes for that. But this is explaining research in new populations. So in this session, we're going to be talking about things to think about when speaking with non-English speaking populations, with children, and also discuss some key equity and inclusion considerations while we're doing all of that. So I know there's a few filing in, but in the sake of time, we'll just go ahead and jump in with our first speaker. Our first speaker is Maria del Carmen Reyes. She is an NP with 24 years of experience working in pediatrics at the Children's Hospital of Los Angeles. She started as a bedside nurse, caring for people with CF as an inpatient, and then she transferred to the CF Care program, where she began coordinating, and now she's conducting clinical research and providing outpatient care as her nurse practitioner. She's been part of the CF research team for more than a decade, and she's been involved with the TDN, including the TDN Steering Committee, RC Advisory Council, and Equity in CF Clinical Research. She is a native Spanish speaker and regularly provides clinical care as well as patient recruitment and informed consent in Spanish. So let's welcome Carmen.
Good morning, everyone. Nobody asked me if I should go first or last, but I guess I'll break the ice here. Thanks for coming so early in the morning to join us. It's always a task to wake up when you're from the West Coast coming to the East Coast. So thankful for my team members who are here as well. And I have no conflicts of interest to disclose. So as a native Spanish speaker, of course, I'm going to talk about the non-English speaking community or limited English speaking proficiency community. So that's going to be the focus of my discussion. And from the rationale, you can see there that we are the second largest Spanish-speaking population in the whole world here in the United States. And as you know, studies have shown lack of progress in non-English speaking research participation in the last decade. And historically, we have been excluded, and our shift is towards inclusivity. And so we need to diversify our clinical trials for generalizability, application of clinical results. So this is where Spanish speakers live in the United States. And this is data from 2017. And reflecting people 5 years and older, which of course you know probably has changed by now. So California is very heavy in Spanish-speaking consensus numbers here. And then we have Texas, Florida, Nevada, of course. So very much on the West Coast is where we predominate, but you're getting some on the East Coast as well. So why engage the Hispanic Latins in research? Well, we are 55 million here in the United States. 22 data shows 65 million is the estimate. We are 17% of the population, and 1 in every 6 people is going to be a Latin Hispanic, and 1 in every 4 child is going to be a Latin Hispanic. For those of us in pediatric research, we have to consider that there are 2 million children in the US belonging to families of non-English speakers or limited English-speaking proficiency. And children whose parents don't speak English experience communication-related adverse events, medical errors, and more mortality than their English-speaking peers. CF of Hispanic Latin origin have a higher mortality rate than non-Hispanic Latin patients with CF. And patients of Hispanic origin with cystic fibrosis are the largest growing minority, and now we represent 8.5% of patients in the United States with cystic fibrosis. And because research, which is what we all do here, guides and fortifies our progress in the healthcare we provide, but it's still lacking in representation, that further heightens the healthcare inequity that we provide. So it's a little complicated, these terms that have since only come forth, including Latinx, which is date of birth is 2014. So I'll give you a little background, which I think is important when you're dealing with this population. So these terms are very commonly used in the US, and they're used interchangeably, which they are not, so that's not appropriate. But we know we ourselves do it. So Hispanic means an origin of language. So it's a person with ancestry from a country whose primary language is Spanish, a term that was developed by the US Census Bureau. And Latino refers to geography. So it's a person with origins from anywhere in Latin America, Mexico, South America, Central America, and the Caribbean. And Latino, AXO, is Now, because the Spanish language uses gendered nouns, so O is always male, A is always female, being masculine and feminine, implementing Latinx gives it a neutral approach to be inclusive for non-binary and to be more gender fluid appropriate. And just to go back a little bit, so people like in South America, Brazil, they're not Spanish speakers, so they're considered to be Latino, but not Hispanic. So Latinx came to be in 2014. It's not fully accepted in our community. It's a term not a term that is used by Spanish speakers, and it is viewed as an anglicized way to identify us, a linguistic form of imperialism. It's non-pronounceable, non-conjugable. You can't conjugate an X where there should be an O or an A. And it's not one size fits all. And it is not a term that you will see being used in Spanish-speaking countries. That being said, for the purpose of this presentation, I have been saying Hispanic Latin to avoid the complexities of this. And while I think that it should be more inclusive instead of the feminine and masculine language, these are languages that are very, very old. So it would be hard to change. But there is movement in some countries to implement E, which is a vowel, so then it becomes conjugable. So some people are saying Latine, now Latine. So what are some recruitment challenges for this population? The most common reasons for exclusion I have found are our inadequate preparation, our study measurement tools are not available in Spanish, and that's, I know, been changing over the last few years. There's also lack of bilingual staff to recruit from this community, and then we lack diversity in our teams, we lack representation. So non-English speaking Hispanic Latins may distrust government sponsors. So there are concerns surrounding deportations, undocumented parents. You may have grandparents in the home who are not legal. Maybe the children are born here, or they may distrust hospital systems. And then some wish just to remain anonymous and not bring attention to themselves. And I could relate to that growing up here as an immigrant myself. You just don't bring attention to yourself. And there's the effect of socioeconomic factors on participation. A lot of them do not have the time to devote to a clinical trial. There might be childcare issues, elder care, and then parents probably are both working. So how do we rise to the challenge? Well, change must happen at the personal and at the institutional level. Personal is you as a research coordinator have to take the time to understand the community. So it's called investment. Build relationships, and this will lead to trust. Adapt. So be resilient and be adaptable. Listen and learn from them and their preferences. And be sustainable. Do not make this change a one-time ordeal with one family. Make it sustainable. Learn, implement, grow, and then this will become part of your practice. Institutionally, I think we could do a better job in academia, committing to a language equity and supporting this research financially as well. And then budgetary constraints. So we have to ask sponsors to make sure stuff is already translated and available. And then they can further support research inclusivity of this population by having those tools available to us. And then provide a diverse range of services, including marketing. So our institutions, hospitals, academic settings can do better about recruitment tools and providing these services and really targeting this population, and this includes graphics, multimedia, monitoring, and analytics. And then we need to build a workforce of researchers who know how to do the culturally and linguistically informed work, to include non-English speakers, and to train the next generation of researchers, which is you. So someday you will hand that baton to the next youngin' that comes your way. And communication is key. So utilize your 5 C's of communication. So you want to have clarity, conciseness, consideration, completeness, and courtesy. And be mindful of how you communicate. So use their preferred language. Be prepared. Have an interpreter in advance. Have written documents in Spanish. And have awareness of your nonverbal communication. So body language, sign, etc., and how this impacts the communication, especially when dealing with a consent you know is going to take longer. Maybe being more relaxed and not seeming like you're in a hurry can speak volumes to the family and the interest you have in investing into them, and how important the message you're trying to convey is. And then identify your team's goals and develop a well-crafted message for this community. Adopt a framework. I have my own personal framework, which I'll reference, but one that works for you, your team, and then get feedback on that framework, and if that works for your community. It may work for you, but it may not be what they need. So I've adopted the World Health Organization Strategic Communications Framework, and they have their principles, which they factor as effective. And that means communication should be accessible, actionable, credible and trusted, relevant, timely, and understandable. And I want to highlight understandable because this is important when you're speaking to them. Use plain language, make it visual. I'm a visual learner, so if you show me a picture, I completely understand, and it'll give me ease. Tell real stories. Share stories of what you've done in the past. Reference maybe successes you've had in that clinical trial, and then use familiar language. And I also want to highlight that we need to tailor the message to our populations, tailor it to the family, and then be transparent. This will lead to credibility, be honest, and this will lead to trustworthiness. Of course, there are a lot of frameworks out there. You can choose that which makes more sense to you and your team and the community that you are servicing. And I'd like to reference a little bit more on knowing your audience. So don't make assumptions about heritage. Hispanic Latins are a diverse group. So I always ask, where are you born? Where were your parents born? What do you identify as? Because there are 60.5 million Hispanic Latins in the United States, and that's 2019 census. It's up to 65 now in 2024. So again, we represent a large population in the United States, Mexican being the largest group, especially in California and those close to the border southern towns. And then we have Puerto Ricans, Central Americans, South Americans, and Cubans. And their Spanish is all very different. I myself sometimes can speak to a Cuban and not understand what they're saying. And some might be offended if you assume they're Mexican. So don't make assumptions because they are a people who are proud and who identify as their origin. So it's super important to just ask. And then we are the largest presence again in California. And then of course, Texas, Florida, New York, Arizona, Illinois, we're growing there. New Jersey, Colorado, Georgia, and New Mexico. But more importantly, know your center's landscape. I know these patients may congregate more in some regions and maybe not. And so it's hard to diversify your team when you don't have enough of this population. But think of the flexibility it would give you as a research coordinator to adapt and to be ready for when this population comes your way, when you do get that one patient that you need to outreach. And so we've learned our own center's landscape, which I'll show next, but gain their trust. So establish rapport, calm their fears and perceptions of risk, and personalize the benefits of their participation. And this goes back to appropriate communication. So our CF Center diversity, and I've shown this slide in the past, this is from 2019 data. When we collect information on their ethnic background, there's always white or non-Hispanic white, or maybe most of the time you just have to fill out or check out the white box. And so when we look at it that way, we have 83% identifying as white. When we break it down further to the left side of you guys, we have 60% actually being of Hispanic origin. So it's important to ask again. While I'm a native Spanish speaker and I connect with them very well, that is not my area of difficulty. I have come across what I think you experience, and it humbles me because I had a patient who is a 15-year-old female of Jordanian heritage who has complicated airway pathogens, who's identified as a candidate for a long-term observational study. The family mostly predominantly Arabic. The mom who comes to the visits with her is non-English speaking. And the second parent is of English proficiency, but with limited time and availability due to work. And so the complexity of the study, though it be mild, the care that we were observing through this study was very complicated and difficult to express in that consent that the products were not investigational themselves. We were asking to track the progress during the standard of care treatment. I really found myself lost. The forms were in Arabic. We use short forms, which again is not ideal, and it's probably very expensive to get all of documents translated into Arabic. But Arabic is a diverse language of many dialects, and the interpreters we get on the video or on the phone maybe didn't speak the correct dialect, so there was already a misfire there, even with somebody who was closely speaking their language. So in those sessions, I'm sitting there watching the interpreter engage, and I felt so like I'm missing so much because there's so much going on, and I'm getting like 3 sentences said back to me. And it was frustrating, and of course, that consent took like longer than an hour. And it was close to being, should we walk away from this? Should we keep trying? Because, eventually that patient rolled over into the second part of the study, eventually completed, and then came back again for another round. But if we had not invested that time in that moment, probably the success of having her enroll in Part B or come back as a new subject through Part A again would not have been there if we had not invested the time. And although Mom and I can't speak directly, I could tell that she was grateful for the amount of people in the room, for the amount of time and care we committed to that. But I commend you all for taking the time, those who have done it, because I really hadn't really felt as disoriented and incompetent doing an informed consent as I did in that moment. These are my references, and I will take questions.
Thank you, Carmen. That was a wonderful presentation. If you guys want, there's 2 microphones out here. If you want to come up to the microphone to ask your question, feel free, or you can also put it into the question and answers to the NACFC app.
Or we could do it at the end. Oh, no, it's in there. They can ask it.
Buenos días, Carmen.
Buenos días.
Thank you for that talk. That was really good, and I think that it's always a good reminder for all of us to be, conscientious of the populations that we work with. I'm curious as to if you mentioned knowing your communities and these frameworks, and I'm curious as to if you think, like teams benefiting from cultural competency workshops and implicit bias workshops, and, if the TDN would be, or the CF Foundation would be, open to providing those resources and that type of training as well, that sometimes I think gets missed when you're onboarding. And then another thing that I was thinking about is, although we have made, substantial progress with having documents translated in Spanish, sometimes there's a lack of comprehension. And as a native Spanish speaker myself, I think that when I work with some patients, I can sometimes gauge that there is a gap in that understanding. So I wanted to see kind of like the advice that you have with that.
Yeah, great questions. To address the DEI, so most academic institutions do provide DEI training. That is very affordable to me in Los Angeles, right, through our institution. They're very honed in on that. And I know there have been conversations with the CFF/TDN on whether that's something the TDN should offer, but I think the accountability does go back to our institutions to start there. And of course, onboarding, that didn't even come to mind until you said it. It is important to onboard people and to provide that training early on. It's become more of a requirement as of late, but what I don't want it to become is a checkbox for human resources to say you've done the training. When I went through my own training, I had to reflect on my own implicit biases, right? Some of those microaggressions that you hold that you don't even know, because I'm surrounded by people who look like me. I'm dealing with the community who looks like me, but that doesn't mean I don't have microaggressions towards other populations. So it can be a moment of reflection if you are open. So the openness to learn and to engage has to come from each individual. And those sources will come to you once you start looking for them, right? So, I'd love for Patty and Jill to add a little something on the DEI at the leadership level from the CFF, but I think overall it's the onus is on us to seek it, but also for our immediate institutions to provide it. With regard to the other part of your question, you have to, after you've been doing this for a while, you read their body language, you see that glossy-eyed look. And I often use the tool of asking, and I pause. So take pause. Are you understanding? And sometimes they're intimidated or they don't want to seem like they're not understanding, but you can tell that there's a misfire, a disconnect. I use a lot of colloquialisms to discuss these consents, and I do a lot of examples, analogies, to be able to target until they understand and ask for feedback. So communication loop, tell me what it is you understand. first thing I open with is, do you know why you're here today? Do you know who I am and why I'm here? And if they say I have no clue, then I go into the details of why. But more importantly, read their body language. You know when someone's not connecting the dots. And it's not offensive to ask them, are you, I think it'll give them ease if you ask them versus them having to say, I don't understand. Yes.
I was wondering if you had advice for finding a translator for study materials like that you. How do you actually trust that they've translated stuff correctly? Because we recently had to translate a survey on LGBTQ related topics, and we got it translated, and it was only by chance that we realized as we were putting it into REDCap that the translator used the terms for sex and gender totally interchangeably, which ruined the survey. But it was an accident that we noticed it. And I guess how do you, when you don't speak the language, when no one at your institution speaks the language, like how do you make sure you're not making a mess?
I mean, that's the million-dollar question, right? Because I've come across things. I mean, I could be watching a movie and it's in Spanish and I see the English subtitles and or vice versa, and it's frustrating when I see medical shows. I'm like, that's not at all what it says, right? So I feel like I have the inside scoop, and so there's errors I've caught. And while I'm allowed to obtain consent in Spanish, I've gone through the testing. The hospital limits us in text, right? So I can't translate documents. But that is definitely moments to invest financially into making sure these documents are correctly. The onus shouldn't be on you as a non-Spanish speaker to make sure they are correct. Me as a Spanish speaker, I can read it, and you have to notify people it's incorrect. But yeah, it's challenging, especially with a survey that will change the responses and potentially discourage people from participating. So your institution should commit. I mean, even interpreters in Spanish, again, the languages in Spanish may be so different, and they might be using a word that is not a broad use word, maybe more unique to a specific population. But that is, I think, a problem we'll come across. There's no overarching answer to support every institution and how they do things, but we should hold them accountable. Thank you for that question. Jill, hi.
Hi. Thank you so much, Carmen. I'm just going to comment a little bit on the previous question about what resources may or may not be available through the TDN. So as Carmen said, a lot of institutions offer DEI training, and I think one thing that might sometimes be lacking in that DEI training is the element of clinical research. So I think there's really great DEI training, hopefully, that most people can access through the institution. We do know that Duke University has a course, online course called Just Ask. And it's quite good. It's very oncology based, so there's things about it that aren't as relevant to CF, except for my take home from it really was about really meeting people where they are and really understanding all of the underlying issues that might prohibit or restrict someone from wanting to participate in research. So I personally thought it was good. And then I think the other part where the focus really is from the foundation point of view is in the PEP program and the Partnership Enhancement Program. And I think that group is also looking at how they might incorporate more elements of cultural differences. But at the end of the day, PEP is really about asking questions and meeting people where they are. So I think there's opportunities for a lot of really good training through PEP, and then adding that cultural competency component on top of that.
Thank you, Jill. Sharon.
All right. It is work. So I'm wondering about institutions partnering with interpreter services to help the interpreters learn more about research, and have had that experience at your institute at all, or do you have suggestions about how to go about that?
Yeah, that's definitely like finding a unicorn when they are trained in research. We have very few, and they are primarily routed to oncology, our main competitor, right? Because we are still an orphan disease, so they hire their own people. And our interpreters used to be in-house, and now they do a lot of contracts, outsourcing. But we do have people trained in research. We have a live interpreter in person in our clinic when the clinic is open. but they are not comfortable with the research. And when I brought them into the fold of, well, when my colleagues have brought them into the fold of these conversations, they feel they're uncomfortable. They're even uncomfortable signing where they are the interpreter, right? Because they don't know what this implies. So I do most of the Spanish consenting for those reasons. It just makes it easier. But there is a gap there that needs to be addressed. So these interpreters who are proficient in research are more expensive and undergo additional training. But yeah, we need more of those. Thank you, everyone.
Thank you, Carmen. That was really fantastic. I have the pleasure to introduce someone who's been a mentor to me for a very long time, and our next speaker, Sharon McNamara. Sharon is a research nurse manager at Seattle Children's Hospital and has extensive experience in the development, coordination, and implementation of clinical trials in CF and other pulmonary indications. For the past 30 years, she has been involved in therapeutic trials, both investigator and industry-initiated, and multi-center and observational studies. As a lead research coordinator, she has developed templates and tools for the use by many study teams and has been involved in research coordinator and investigator training programs through the CF, TDN, and CFF. So it's my pleasure to welcome Sharon.
Thank you, Heather. I wasn't sure what you were going to say about me since I didn't send you anything. I'd like to say thank you for this opportunity. And what do I do next? Or Whoop. So I was asked to talk about consenting children in research, but I kind of changed it to enrolling children in research. And I'm going to kind of take you along a random path, talking about what it means to enroll children in research and what considerations there are. I have no disclosures. So here are some of the main tenets that I'm going to be talking about this morning. Children represent a vulnerable population. They're not small adults, but there are really important reasons to include children in research. There are additional protections for children under the federal regulations, the DHHS Code of Federal Regulations, and these are primarily centered on consideration of both benefits and risks, and benefits too. And I just want to bring you to this, for those of you who do not work with children, working with children in research is both complex and fun, and that's why we keep doing it. So I'm curious how many people in the room do work with children. Oh, a lot of you. Okay. So for you, this is going to be like, okay, I know all that. But hopefully you'll take away some pearls and feel like you know this population. And so, as I said, children are not small adults, despite the fact that they sometimes want to be, as depicted by the photo on the right here. We need to think about that they're not small adults in terms of their physical development, their size, their body proportions are different. They have a wide range of normal physiologic parameters. Think about heart rate in a 2-year-old is very different than what you'd expect to see heart rate in a 14-year-old. Their metabolism and excretion differ from adults, and that affects drug uptake in tissue. Cognitively, their information processing is all over the place. Their decision-making is non-existent, even as if you're 15. And think about the impulse, the risk-taking impulse, which changes over time. So you may not want to take a risk if you're a 7-year-old, but again, if you're a 15 or 16-year-old, you may have a different take on that. And their sense of time is totally different than an adult's, which is going to play into how we get assent and how we conduct our study visits. Emotionally, their ability to modulate their responses is going to be different. Their tolerance of discomfort, and children are dependent on trusted adults, and some of those trusted adults become the study team. So why must research include children? It's really critical to understand the differences from adults. This is similar to understanding the differences in men and women, and we've all heard how much research has been done in men, particularly around drug development, and metabolism in women may be much different. similar situation in children. New interventions or descriptions of a population must really account for differences in pediatric populations. Drug dosing is different due to volume of distribution in tissues and metabolism and clearance. And for any of those of you who are working in pediatrics, and especially working in development of new drugs, I would encourage you to learn what you can about drug metabolism. I found it fascinating when I first started, and it made all the difference in the world to me about how I looked at protocols and how I was able to read the outcomes of those studies. Even outcome measures such as symptom scores need to be adapted based on developmental capabilities. And I think we've seen the CFQR developed differently for different age groups. The CRIS scores have been developed differently. And those take a long time to figure out how to get a 5-year-old to do a symptom score. And there are also federal requirements under DHS to conduct research in children. So what are the clinical trial design considerations? And some of this comes from the literature. So clinical trials in pediatrics should minimize the numbers of children involved and the numbers of required procedures, while also ensuring data integrity to answer the research questions. Discomfort and distress that could be caused should be minimized. We should allow for flexibility in procedure schedules, and I would implore any of you who are on the protocol review committee and reviewing pediatric protocols to think about this. We've seen protocols where a sponsor is like, you must do these things in this order. That works great for an adult, but it does not work well in the pediatric population. And recognizing that phase 1 studies are very rarely conducted in children. They're only conducted in children when the population is not available for study at an older age, unfortunately because children die. So a good example of this is spinal muscular atrophy, in which even the phase 1 studies could only be done with infants and toddlers because those children do not live to adulthood. And these are equally important considerations in investigator-initiated studies, which many of us may be involved with at our site, where you have an investigator who's like, let's do this study in these kids, and we're going to ask them to do all these things. And we as research coordinators have to represent those children and be like, let's think about this. So going back to minimizing the discomfort and distress while also being able to answer the research question. Coordination of research procedures with clinical care is more important than it is with adults. And I'm sure that all of you in this room who work with pediatrics know that coordinating blood draws for clinical labs, coordinating throat swabs is really important. Inclusion by age is based on the phase of the study. Phase 2B studies may enroll adolescents, but most of the younger cohorts are going to be enrolling in phase 3 studies where we're looking at some safety, but looking at efficacy and other things in that population. There are limits to blood volumes and risky procedures, and it's really up to the IRB to determine the risk and benefit of participation. And this then has implications for consent or parental permission and assent. So I just want to go quickly through some definitions. So we all know what informed consent is. There's disclosure of information. The person providing consent must be competent to make a decision, and it must be voluntary. The doctrine of informed consent has only limited application in pediatrics because only people who have capacity and are legally empowered can provide effective informed consent for themselves. And that, unfortunately, does not apply to anybody legally under the age of majority in your state. And capacity is really dependent on the person. So that brings us to parental permission, which we often refer to as consent, but it's really parental permission. And this aims to protect a child from assuming unreasonable and unjustified risks given their immaturity. The parent must receive all the necessary information similar to consent and have the opportunity to make that voluntary choice. And because a child cannot legally provide consent, permission by at least one parent or legal guardian is required before a minor is enrolled in a research study. And again, that risk category by the IRB may require signature from both parents if the parents are available. So what is assent? Assent is separate from the parent or guardian's permission for the child to participate. And I would like to point out that assent should always follow parental permission. We shouldn't be getting assent from a child before the parent has given permission for that child to participate. And I'll talk a little bit about that timing. There should be reasonable effort to enable the child to understand, to the degree that they are capable, what their participation would involve, and we should be able to verify that they understand. They should have the opportunity to decide to start the study and agree to continue. So assent is an ongoing process, whether it's for a single study visit or for a 5-year study. And the amount of information and the timing is age dependent. So here are some examples of the assent process and documentation. And I want to point out that neonates are in a separate category of under the Code of Federal Regulations. So they have even greater protection than a 1-month-old. So for children from 1 month to 2 years of age, we're going to get parental agreement. And how are we going to know that the child is assenting to being in the study? Well, they're assenting by somewhat cooperating during procedures. Again, that degree of cooperation is going to depend on what you're doing, but is really reliant on the research coordinator to know pediatrics and to be prepared for that visit. Children from 3 to 6-year-olds can give verbal assent for procedures during the visit, and that may look like as simple as, we're going to do your height and weight, and we're going to check your heart rate and your breathing. What would you like to do first? And allowing them to participate, and by that measure, they are giving their assent for that participation. They don't know what the study's about. They just know that they're there, and that they're there with trusted adults. For 7 to 11-year-old children, more detailed information should be provided at enrollment. They should know the reason for the study, what the procedures are in very simple language, how long it's going to take, that they have the option to stop, and that this is voluntary. And children at this age often are given an assent form. Again, this will be dictated by the IRB requirements. And that assent form should be at a 3rd grade reading level. So 3rd graders are 8 years old, so pretty low. It's a very simple form. And there are times when I will say to the parent, why don't you read the assent form first before you read the parental permission form, just to give them an overview of the study. Ages 12 through 14 kind of fall into a gray area. So the research team really has to use their judgment depending on the complexity of the study, which of the required elements would be most appropriate. And then ages 15 and 17, the assent form is very similar to the parental permission or consent form. And at our institution, we tend to use the consent form that would be used for adults and the parental permission form as an assent form for those teenagers. Those forms should be written at the 8th grade level, and there should be written documentation of assent unless for some reason there's a waiver by the IRB. Call out to the CFC or NET toolkit. There is an assent checklist, which contains a checklist about what elements should be in the consent, so you can go ahead and find that there. I'm going to talk a little bit about the federal regulations and the risk category. How's my time? So under the federal regulations, there are 4 permissible categories for research involving children. And this is different, again, than research involving adults. And these categories, as I've said, are based on the degree of risk and the type of prospective benefit. The categories are described in relation to minimal risk, which is defined as the probability and magnitude of harm or discomfort anticipated in the research is not greater than those ordinarily encountered in daily life or during the performance of routine exams or tests. And I was on the IRB quite a while ago, and there would be great debate about what is the definition of ordinarily encountered in daily life. So for a child who does not have a chronic illness, getting a blood draw might be more than minimal risk. But for a child who has blood draws recently, maybe having blood draws falls under that category of encountered in daily life. So the IRB makes the risk determination with the implications for parental permission and assent, and that risk category is documented in the approval letter. And it's important for us to know what that determination is because it will have implications for our parental permission and assent forms. So just to go quickly through this, category 1 is a minimal risk determination, not involving greater than minimal risk. There doesn't have to be any benefit to the child for this to be IRB approved. There's permission of one parent and assent of a child who's 7 years of age and older. It may be verbal assent, it may be written assent. And some examples of this would be single blood sample collection, retrospective data collection, and the IRB may even waive parental permission if it's not an FDA-regulated study. Category 2 is greater than minimal risk with direct benefit to the child, and I think this is the one that we see most commonly. And if you're really in the know, you can see that I've highlighted there in green that this is a 405 study. So that's how regulators refer to this. Oh, it's a 405. So that means that it's research involving greater than minimal risk, but there's prospect of direct benefit. So an example of this would be an industry study where there has been proven efficacy of a treatment in adults, and there is likely to be benefit to other populations. So the child might be assuming some risk to be in that study because of the study procedures, but there's likely a direct benefit. So as I put here, a new type of therapy to treat Pseudomonas with evidence to support efficacy, or maybe it's established clinical care that you're changing. For example, a new approach to treatment for pulmonary exacerbations. And as I said, most of our clinical trials fall into this category 2. Category 3 is greater than minimal risk with no direct benefit, but likely to yield generalizable knowledge about a subject's condition. And I think the thing that I want to point out about this is that this category, which is 406, requires two-parent consent if both parents are reasonably available. In a study, one of the studies that we're doing right now, the BEGIN BAL study, falls into this category. So that's a good example of the BEGIN study in itself is, I don't even know what category it is. It requires one parent permission. But for the BAL study, it requires two-parent permission because it's greater than minimal risk and is not likely to yield, there's no direct benefit to the subject, but it's going to help us learn more about CF. Category 4, I'm not even going to talk about. This is a very rarely approved, requires lots of review by the Secretary of the Department of Health and Human Services, and I, in my experience, have never experienced Category 4. So I want to move on now to just talking about what I call navigating the parent-child landscape in consent and assent. And there are factors which are going to make it more likely for a child to assent or a parent to consent to have their child enroll in research. And we run into these situations where we go in to talk with the family. We're like, all right, this family is eligible to be in this study. We're going to go and talk to them. We may or may not know them. And what we may encounter is that the parents are really interested in the study and the child is like, no way. Or the child is like, heck yeah, and the parent is like, no. So there are different factors that play into this. One is family familiarity with research. Hopefully they've had positive experiences in the past and are amenable to hearing more about research. The relationship with the provider and or the research team. And I think we've heard a lot that having a provider provide an introduction to a research study can be really key in the family interest in participating. Both the parent and the child may have concern about or perceptions of the risks which need to be discussed, and also understanding of the potential benefit. And so talking through those in different ways with both the parent and the child is important. Looking at the time commitment, the visit number and frequency is going to play into this. What's the compensation for the visit time? Is there reimbursement for expenses? And just what are the family dynamics and interactions? We had a study, we had a QI project recently that the dad signed and the child signed up to be in the QI project. And it was a home spirometry project. We sent the child home with a home spirometer and they never did it. And we were like, what's going on? And we finally got in touch with the mother and she's like, I didn't sign up for that. And I'm the one who's at home. So kind of like knowing and I think, what Carmen was alluding to about, the parent who's the decision maker may not be there at that time when you're talking to a parent about a study. And so just getting to know the family is really important if you don't have previous experience with them. And as I mentioned, assent is ongoing. And why is it ongoing? Allowing a child to have the voice in the room to say, yes, I'm willing to do this, or I'm not willing to do this, is so important. It really helps them build trust in the world, and that's what we want. It minimizes their psychological trauma. It creates relationships for this particular study and also for future research. It ensures that we are able to collect key data by completing procedures per the protocol. If the child isn't trusting you, they're gonna not want to do something, and we're gonna miss that key data that's important maybe for that approval of that drug or to learn more about that new PRO that we're developing. And in particular, in pivotal pediatric trials, we often have small numbers of patients who are able to enroll. And their ongoing participation can be really critical to having enough data to get approval of that study drug. We want to avoid or minimize dropout to meet the study endpoints. And that ongoing assent will also ensure that the patient is eligible to continue in the study. So parental support is also crucial to ongoing assent. The parent is in the room with the child for many study visits and procedures, and preparing them and planning ahead is important. Checking in with them about their experience. I had a mother say to me recently, nobody ever asks the parents what it's like to have their child in research. And that really hit home for me. And they are also involved with support of the child at home with study drug procedures that we're asking them to do. So we're not only enrolling the child, we're also committing the parent to doing something. And the RC has to understand the risks and discomforts and benefits of a procedure in the moment. So I just want to talk a little bit from an age perspective. For infants, again, parent permission, planning for the visits and procedures. We'll make calls to parents ahead of time and be like, here's what we need to do. How should we approach this? How are things going at home? Is there anything that we need to know? For toddlers, it's really important to be efficient. They have no patience. And using distraction is important and fun. And just remembering that protest is a normal developmental behavior. And reassuring parents also sometimes are like, I don't want you to think my child is misbehaving. They want their child to be good. And we're like, it's okay. No, this is fine. And they get over it quickly. For preschoolers, play and participating in study procedures is really helpful. You have to build in breaks, little rewards, gain their cooperation. And even at this age, I've had 5-year-olds be like, I'm going to be in the study because it's going to help other people. So you start to see that beginning altruism. Again, 6 to 12-year-olds planning and participating. These kids have an understanding of time. So they're able to see, oh, we have these 5 study procedures to do. They have some concept of like what 30 minutes is, what 4 hours is. And really, this is the group that we're engaging in ongoing discussion about why, reminding them why they're doing the research and really partnering with them. And then for adolescents really discussing the options to continue. They have more independence in home management and really reminding them how they're contributing to science and potential progress in treatment. And in our state, we have HIPAA considerations. In our state, at the age of 13, adolescents are protected in terms of release of mental health and reproductive information. So again, something to know about particular to your state laws. We're not going to do takeaways yet. Okay, now we're going to do something fun. Alan, can you come on up? So now we're going to have a little break. We're going to do 2 skits to kind of show you some. No, I think we're going to come up here because I don't know if we're going to be able to hear down there. We have 2 skits to share with you. To kind of.
Is time enough to do these?
Yeah, I think so. Is there time? Okay. We're going to do 2 skits, one of which kind of highlights a discussion that is necessary but sometimes challenging, especially for pediatric nurses and research teams. So Alan is going to be the RC, and the skit involves a 16-year-old female who comes to a screening visit with her mother. They're already well into the consent discussion and now moving into safety issues.
Let's talk about safety. Do you know what tests we will do to evaluate safety during the study?
Oh, I get to be a 16-year-old. Well, blood test, obviously.
Yes, yes, we will do blood and urine tests to check your liver and kidney function as well as your blood counts. We will check your blood pressure, heart rate, and breathing rate, and do physical exams, and we'll be asking about any changes in your health. There's also pregnancy testing for any female that has started menstruating. Have you started menstruating?
Well, yeah, I got my first period about 3 years ago.
We have to do pregnancy tests multiple times during the study. Would you tell me your understanding of why we need to do pregnancy tests?
To make sure I'm not pregnant.
Yes. We don't know how the study drug could affect a pregnant woman or a growing baby, a fetus. So it's very important to prevent drug exposure to a pregnant woman. Are you comfortable with me asking you some questions regarding sexual activity?
Yeah.
Would you like your mother to step out while we talk?
It's okay. I guess she can stay.
Are you sexually active?
Well, I have a boyfriend.
Are you and your boyfriend having intercourse?
Not yet.
Is it possible that you both may have intercourse in the near future?
Well, yeah, and I've actually discussed birth control with my mother.
Are you considering starting oral contraception?
Yeah, I'm thinking about it.
Choosing not to have sex, in other words, abstinence, is one acceptable method of birth control for the study. However, given what you've said, and that you and your boyfriend could have sex in the near future, I'm going to suggest that abstinence is not a reliable method for you to be sure that you don't become pregnant.
Maybe my mother should step out of the room.
Some options to think about would be either to start oral contraception or having an intrauterine device placed. Both are acceptable methods of birth control for women enrolled in this study. Even after you start one of these forms of birth control, it would still be required that your boyfriend use a condom while having sex during the study and for 3 months after the study ends. This is an additional requirement that is 2 methods of birth control. So it's a discussion you need to have with him too.
Oh, boy. Does he have to give consent too?
No, not technically, no.
Okay, I'm off script. Okay, most important to me is not getting pregnant, and I do really want to do this study. So let me think about this some more. I want to talk to my mom and my boyfriend.
That's a great idea, Naomi. What's most important is to consider your personal needs at this time in your life. We can have further discussions about the study anytime you like.
Okay, so Alan actually wrote this script. This is my dear colleague and friend, Alan Genitosio, research nurse at Seattle Children's, who plays guitar with our study patients. We wrote the script because this can be a difficult conversation to have, and as pediatricians and pediatric nurses, we're not very skilled at having these conversations. So keeping pregnancy and contraception in mind is important, and role-playing can be a really great way to get comfort with these conversations. So set up some times with your colleagues. Okay, second situation is an 11-year-old is in an industry-sponsored clinical trial. Sarah's going to be our doctor, our PI. And this child has a history of occasional syncope with venipunctures. They're very athletic. They're a runner and play soccer. And we've had steady EKGs flagged as abnormal intermittently, but we also do a hospital EKG, and the overread by the hospital cardiologist has always been normal. And our PI is aware of these discrepancies. So we had a spring study visit with this patient and their mother. And Alan, you're going to be the RC.
So RC and parent. How are things going with the end of the school year coming up?
Well, Daniel's really busy with after-school sports, which he loves. But interesting, recently he's been really tired. He's actually falling asleep some days after school on the couch at home. He's falling asleep in the car, and he even fell asleep at dinner the other night.
That does sound unusual for him. Are you concerned, and should we talk to Dr. Gibson? I can think of a few things that would be worth considering. Is there anything else that has happened?
Well, the other thing that happened is that he actually passed out for a few seconds on that hot day last week. But you know how he is. We were right there and he came too quickly. We had him drink and eat something and he seemed fine. So I don't really think much of it. You know how he tends to get lightheaded.
Yes, he does have that tendency. I'm glad that you were there and Daniel responded and came too. Does he seem worried about it?
No, he doesn't seem worried at all, and I'm not super worried either. It may be the end of school and he's really starting to grow. Maybe you could talk with Dr. Gibson and get his thoughts. We're also seeing our CF clinic provider in clinic in about 6 weeks, so we can talk with her. I'm wondering if he needs a sleep study as much as he's falling asleep. He's also having an OGT then too. So just as an aside, I was concerned with this kid about cardiac issues and about blood glucose, so I went and talked with the PI. He reached out to cardiology to review ECGs and was reassured again that they had been normal over the past 3 years. So I sent a message to the mother. And then there was an August CF clinic visit, and the dietitian note says that the parents reported 3 syncopal episodes over the past 2 months, not reported to the research team at all. So, you want to start there?
Continue?
Yeah. So then I made a phone call to the mom.
Hi, I thought I'd call and follow up on Daniel's last CF clinic. His OGTT was normal. I see in the clinic notes that a sleep study has been ordered and scheduled for January. I also see a note that he had a few more fainting spells this summer. I'd love to hear more about that, given his enrollment in the research study.
Oh, yeah, sorry that I didn't tell you. So it happened 3 different times. Once right after school got out, and once when he had a friend over to spend the night, and again after we had friends with us during that heat wave. Each time it was just seconds and somebody was there with him. I'm not sure what to make of it. I did forget to tell our doctor at CF clinic, but I told the dietitian because I was wondering if it was his blood sugar.
Let me talk again with Dr. Gibson and his CF clinic doctor. They may want to do some more tests. Is that okay with you?
Yeah, that would be fine.
I don't think it would be, I don't think it's related to study drug after being in the study for 3 years and on study drug for 3 years, but we want to be safe.
All right, so the RC goes to talk with our lovely PI here.
Daniel's had 3 more syncopal episodes over the last several months and is falling asleep randomly at home and in the car. I know he's a growing adolescent, but this is a big change. He's scheduled for a sleep study in January. I'm worried a little bit about cardiac issues that we've talked about in the past, and he's a big runner too.
That does seem unusual. I don't think it would be related to the study drug at this point, but we just need to be sure and be safe. So I'll reach out again to cardiology and talk with his CF clinic provider. I'm thinking maybe we should try a Holter monitor to get some more information about his heart.
I would feel better about that, and we'll let Daniel's mother know about the plan.
So I'll finish this up. So 10 days later, I get an email from the mother. Dear Sharon, I had a talk with Daniel about the fainting spells and how tired he seemed sometimes, and I let him know that the CF doctors were ordering some more tests to check his heart and his sleeping. He was very quiet, and then he said he had something to tell me. Apparently, each of the times he fainted, he had been awake almost all night playing games on our family tablet. He was getting out of bed after we were asleep and taking it to his room. And the days when he was falling asleep, he's also been up part of the night playing too. When he's falling asleep, he's also been up part of the night too playing. I never imagined this would be happening. I guess he's growing up and doing normal 11-year-old things. I think I may be grateful for that explanation. I've canceled the sleep test, and please let Dr. Gibson and the CF clinic doctor know too. So the takeaway for us for this was that kids are growing up. He's been in a study for quite a while, and he's just changing developmentally, normally, and totally overlooked that. So it was a really good reminder to put these adverse events in context and to explore more with both the child and the family. So. All right. Takeaways. So we as research coordinators and research teams need to ensure the protection and safety of the children and adolescents enrolled in our studies. Relationships are key to ongoing ascent. This requires co-production with parents and children, understanding developmentally where the child is and allowing for growth and change. Visit preparation is essential. Acknowledging discomforts is really important too, while supporting coping, building in fun and reward, and acknowledging both parent, patient, and family contributions to science and clinical care. Thank you. I probably used up all my question time.
So in the interest of time, we can do one question. And I know that there's a bunch of questions in the chat. So I'm going to volunteer Sharon to stay a little bit after, and she can answer any extra questions that you guys may have.
Sure.
Does anyone have one that they want to ask in the microphone, or I can just take the first one off the chat?
All right, chat it is.
Chat it is. Okay, so when you consented, did you have an impartial witness who spoke the same language as the parent?
Sorry, I didn't realize we were going to do it right now. I'm sorry, can you say it again?
I'll get it done. Get this one done. So the first question in the chat is, when you consented, did you have an impartial witness who also spoke the same language as the parent?
We do not have an impartial witness for people whose preferred language is English. We don't, for people who speak a language other than English, preferred language is a language other than English, we have an interpreter. But that person would then be the impartial witness, so yeah, that makes sense.
Thank you, Sharon.
Thanks, Sharon. Our next speaker is Jessica Hudson. Jessica currently serves as the Senior Lead of Clinical Research Engagement and Equity at the Cystic Fibrosis Foundation. In this role, she leads efforts to partner and engage with patient advocates, caregivers, and thought leaders to understand the experiences and needs of the patient community and bring those patient perspectives into cystic fibrosis care and research. Jessica also leads efforts to improve diversity in community engagement and promote equity, utilizing quantitative and qualitative research methods. Prior to the CF Foundation, Jessica has also led research teams in areas such as behavioral health, infectious disease, and the rare disease, working to increase diversity in clinical trial recruitment, including creating spaces to connect and educate local communities on study-related topics and opportunities to participate in research. So let's welcome Jessica.
Awesome, thank you. How do I move back? I didn't realize they were going to read the full bio, so apologies for that. Okay. Okay, perfect. Awesome. So as Heather said, I'm happy to be here to talk about equity and inclusion considerations when explaining research to new populations. This is our NACFC disclaimer. I'm CFF staff. So a quick overview of what I'm hoping to cover today. I'll start with the overview of health equity to kind of ground us in that definition, and then share a little bit about research-related disparities to, again, help set us up for the discussion. I'll also give a brief overview of some of our listening efforts to date with underrepresented groups, including communities of color, as well as those who are currently not benefiting from modulators. And then we'll talk about equity and inclusion considerations. So what is health equity? For the sake of time, I'll just read the beginning of the definition, which I think does a great job to set the stage, which says health equity means that everyone has a fair and just opportunity to be as healthy as possible. And I always like this picture because I think it does a great job of showing us a difference between equality and equity. So you can see in equality, everyone received the same intervention. However, that did not solve the issue for everyone. But when we look at equity, each individual received an intervention that met their specific needs, which solves the issue. So why is health equity important in CF? We know now and have known that CF affects people of many different racial and ethnic backgrounds. However, we have dismissed their stories. And because we've dismissed these stories, we don't currently have adequate recognition or representation of people of color in the CF community. So it's just a reminder that these stories and these experiences can teach us how to do better and be better, but we have to be willing to listen. So what do we know as far as disparities that exist as it relates to research in CF? When we looked at 29 studies over 15 years, Hispanic and Black people with CF make up only 2% and 1% of participants in our clinical studies. When we think about access to therapies, 30% of Black and Hispanic people with CF are currently not candidates for modulators. And we look at each CFTR modulator, Black or African American patients are actually the least likely to have eligible mutations when compared with their white counterparts. So to set the stage for some of these considerations, I thought it was important to share some of our listening efforts to date. So as a general overview, we've done quite a few listening efforts. In spring of 2020, we did one-on-one interviews with folks that were already engaged in our programs. This was open to all people of color that were currently engaged, and these were high-level interviews to just start to understand the engagement experience of these individuals to help start to inform some of our racial justice work. In summer of 2020, obviously, tragedy struck across the country with George Floyd and Breonna Taylor. And we wanted to expand our efforts in that space. And so we launched a large survey to all people of color in the CF community to really understand what engagement barriers folks are experiencing. And when we say engagement barriers, we mean barriers to care, research, and being involved in the CF community. And in this graphic here, it's just a call out from that survey where we had 3 statement agree questions that I think are relevant for us today. This first one says, it is important to me to have a voice in the CF community, and 75% of respondents indicated they strongly agreed that it was important to have a voice. We then said, I currently feel included in CF research, where only 26% of individuals agree with that statement. And then we said, I currently feel included in the CF community, where only 24% of individuals agree with that statement. So I think that's always an important call out because we don't want to make assumptions about interest in research or interest in having a voice. There's clearly interest there, but there are barriers that exist. So fast forward to summer of 2021, we launched the Communities of Color focus groups to really do a deeper dive into some of the themes we heard in that survey. And so we utilize those focus groups, again, to dive deeper into those themes and really investigate what engagement barriers these individuals are experiencing and also what are some of the barriers to trust as well. So 3 major themes emerged, which were representation, resources, and education, and that is kind of how we frame the rest of the talk. So diving a bit deeper into the focus groups, I pulled out some of the themes that I thought were related to the talk today. We heard that individuals feel there is no research happening for those that are not eligible for modulators. And this has left a lot of folks feeling left behind and really checked out. So when they receive emails about research or things about webinars, they're already checked out and kind of have this thought process of that's not for me. There are feelings that information is actually being withheld when we think about treatment and ongoing research. There's a lack of trust in CF care and research teams and also staff, and this is really due to negative encounters and experiences, often involving stereotypes and bias or microaggressions. Last, we also know that there's a lack of representation in staff, and again, that includes the foundation, care teams, research teams, and also platforms. So when we think about study websites, flyers, our websites, not seeing someone that looks like you can also lead to trust issues. So I included 2 quotes, which were from the focus groups, and I'll read these that say, "I'm new to this and I've never been involved. I didn't want to because I knew there was no one that looked like me." This next quote says, "They didn't want to hear from us before, so why do they want to hear from us now?" We've also recently done some listening with folks who are currently not benefiting from modulators. And so a few themes there. There are really strong feelings from this community of being left behind and deprioritized. And those that are eligible and not taking due to side effects feel even further isolated and even silenced. So those individuals make comments like, when I'm in a room and we're talking about eligibility, they're kind of afraid to even tell their story because they don't want to interrupt the celebration of the folks that are able to utilize modulators. Many are cautiously hopeful, however, and this is really based on recent improvements we've made in our communications, research developments, the programming for this population. So just kind of showing that as we take steps to include these individuals, it is contributing to hope. We also heard the decision to participate in genetic therapy research is extremely layered and requires education and information from a trusted source. And then also want to call out that many of the themes we heard in these interviews are consistent with what we've heard from people of color in the CF community from our previous efforts. So additional perspectives from the interviews with those who are not benefiting. I won't read everything for the sake of time, but I'll read this quote that says, "A tiny little subset of us have had to stay on the Titanic. Everyone else got on the lifeboats, and we're supposed to be happy for them. We are, but it's rough, including listening to everyone else celebrate." Okay, so what are some of the considerations that we can think about and put in place to ensure that we're being a bit more equitable and inclusive? So starting with trust and trustworthiness, and really want to focus on that reframe to trustworthiness, because the burden of trust is not on our patients or these communities, it's on us to become more trustworthy. So what are some of the steps we can take? We want to be aware of and acknowledge past missteps in history. So it helps folks to acknowledge that they're not crazy to not have trust. They're not crazy to be afraid, because we do know that historically individuals have been left out of these spaces. And also important to know that it's not just historical. These things are still happening. As we heard in the communities of color focus groups, folks are still having these experiences that are causing mistrust every day with care or chapter events. So we want to be transparent and acknowledge that these things are real, that they're experiencing. If there's a trusted team member, we want to try to identify that and see if we can leverage that relationship and build more trust. So if there's trust in the primary doctor, how can we leverage that with the research team and build on that? We want to build a rapport with patients and their families and really humanize the process. So when we're having these conversations about research, the primary goal should be to educate these individuals, and secondary being to enroll in a clinical trial. So starting those conversations with, what do you know about research, or do you have any questions about what research is or what consenting is, to just really make those individuals feel more comfortable. And of course, in having those conversations, we want to be able to understand barriers to participation, and that comes through relationship building. Individuals may not be comfortable expressing all of the barriers that they're encountering if they don't have that relationship. So we have to be willing, again, to humanize that process, make sure folks feel comfortable to let us know what those barriers are, so then we can address those. And last, we want to try to create a safe space for questions and misconceptions. Folks need to feel comfortable to ask you questions and ask you or tell you things that may sound crazy, but are things that they may believe, or they've heard from their family members that have been involved in research, or they've heard from their family members that don't know anything about research. So it may be completely wrong, but we have to make it a safe space to tell us those misconceptions, tell us those things that they've heard, so that we can educate and correct. But that takes a safe space. Jumping down to representation, we talked about this a little bit earlier, but diversity of care and research teams is a huge one, right? Obviously, if you don't see someone that looks like you, it feels like you don't belong. And how can this be for me if no one here looks like me? We also want to think about representation in our study flyers and handouts and websites. It seems like a small change, but again, if you constantly see flyers and websites and things that don't show you, or it doesn't show your child, it doesn't feel like a welcoming space, and it doesn't feel like those spaces are made for you. So we want to think about that when we're creating these flyers and these handouts, and ensure that it reflects the diversity of our population. When we think about access, we want to try to provide additional holistic resources to these individuals. So again, when you're having this conversation about research, we want to humanize that process and think about what are their other needs. Because a lot of times, if you can help to meet some of those other needs, it can free up some of that space or mental space to even think about research, right? So we want to connect folks to programs like Community Voice, conferences, Peer Connect, to connect with individuals with like identities, and Compass for additional resources to, again, help individuals make some space to even think about participating in research. We don't want to make assumptions, again, regarding interest in clinical research. We don't want to look at someone and assume they're not interested because of their background or because of our own bias. So we want to be equitable in who we're approaching about research. We should be approaching everyone, and we should be trying to have a conversation with everyone and not making an assumption based on what we see. Again, we want to listen, spend a lot of time listening to understand those barriers, right? Again, it takes relationship building for individuals to feel comfortable disclosing what those barriers might be. So if it's travel or cost or translation needs or even family dynamics, right? If an individual will only feel comfortable if their parent is there or if their spouse is there, we have to build the relationship so that they feel comfortable letting us know that so we can try to act on some of those barriers. And last, and I think one of the most important pieces, we have to be willing to do things differently. We've done this work for a long time, but we've only been able to incorporate one area of our community in one group of people. And so if we are willing to and wanting to bring in additional individuals and new voices, we have to be willing to do things differently. So that can mean longer recruitment timelines, after-hour support, different communication and outreach strategies, to, again, reach these additional audiences from different backgrounds or rural communities. We just have to be willing to take the extra step and go the extra mile. Last, training. It's important, we talked about that earlier, bias training, training on microaggressions. We have to prepare ourselves to receive these new individuals into our space. We need to make sure we're prepared to have these conversations and ensure these individuals are comfortable and feel that we've done the work, again, to become trustworthy. So training on cultural competency, bias, and also, again, another shout out to PEP. PEP has a lot of great resources about how to have some of those trusting conversations, how to build rapport with your patients, and even training around bias as well. We also know it's important to continue to educate these communities again and partner. We cannot do this work to bring in new voices if we don't partner with these communities to tell us how to do this work. So I do want to flag the Community Voice program. I'm always going to plug Community Voice. It's literally the vehicle between the foundation and our community. And if we want to ensure that we have diverse voices that are informing things like clinical trials and care guidelines, we have to do the work to bring those diverse voices into this mechanism. So we really are counting on you to share this program with your patients. I'm happy to answer any questions or share any additional resources with you to get folks connected to Community Voice, but it is really, really imperative. And then when we think about educating ourselves, we have a health equity video, which does a really great job of providing a foundational understanding of health equity, inequities, and some of the disparities that we know to exist in the CF community. So again, really encourage folks to watch that video. We also have a discussion guide live if you want to dive deeper into that video with your team. We're happy to share that with you and help you walk through how to do some training around that video if needed. One more plug, as we prepare for our strategic planning at the foundation, we want to ensure that your voices as well as the voices of your patients are included. And it especially need to make sure we hear from diverse voices. So you can scan here to take the survey. And again, this will inform our strategic planning. So take the survey yourselves, please, please, please. And please share it with your patients. Again, you are kind of our lifeline out to the patient community and ensuring we have diverse perspectives. So really encourage everyone to take this survey and share it back with your patients. Okay, and I'm sorry, I have one more code. This is another code just for you to scan and find out more about what the foundation offers as far as programs and resources for patients and families. And I'm happy to answer any questions. Hi, Jill.
Hi, Jessica. I'm just going to put a shout out for the Research Connection Hub because a lot of these resources are now available there, so you can find it in one place. And I would love to there's something you just said about a discussion guide. I don't think we have that one out there, so I'm going to hit you up for that so we can add that.
Yes.
So it's a great place for everybody. If you go to the resources page, you'll find all this stuff. There's so many resources that have been developed. I think often they're hard to find and they're kind of scattered, and I think we've tried to put them all in one place and organize them. So please go out and take a look.
Thank you, Jill.
Other questions? I don't see any specific for you on the chat.
Okay.
Unless mine kind of stopped.
I did put this in the chat, but I guess it didn't register already.
Mine's
It's fine, though. I don't mind standing up. I have heard that there's a difference between cultural competence and cultural humility. Can you take a moment and explain that difference?
Yeah, well, I can try. I think I think cultural competency is making sure that you're aware and have some at least basic understanding of cultural differences. I think cultural humility is more of a personal feeling of maybe your own culture and making sure that that is not the basis at which you're basing everything else in your other experiences. Is my on the spot answer.
I actually had one, if you don't mind.
Oh, yeah.
You've got a couple minutes to answer questions still. What is a good first step in building trust and with underrepresented groups in research?
Yeah. I think the training piece is the most important first step. Again, it's on us to become trustworthy. And so we have to take the steps ourselves to prepare to hear from these new voices. So really prioritizing training, DEI training, bias, microaggressions, making sure that we're prepared and equipped to address the needs of different populations is the right first step. And then I'll add a part B to that, which is to be transparent throughout the process. We've heard over and over from these communities, they're not expecting us to get it right exactly right now. They just want to be a part of the process and would like to see some transparency along the way. So just being transparent about what your goals are, what you're trying to do, what the gaps are, is a good place to start.
Also, thinking with community voice, we have handouts that we give to our patients when they come into clinic. Is that handout that you had on the picture something that we can print or order to hand out to them? Because I think that it's not widely known.
Yeah, definitely. That flyer is on the hub, right? I'm looking at Katie. Yes, it is on the hub. And it's also available in Spanish as well. So there are, yes, which is also on the hub. So yes, all of those things are available. Absolutely. I think it's important too. It makes me think about access because we can make all these resources, but we have to make sure it's getting out to these individuals. And if they're feeling checked out because they're like, I've been looking at my email for the past 5 years, nothing has been for me, we have to kind of push and go the extra mile to make sure that information is getting to these individuals because it can be isolating to feel like there's nothing happening. So we've definitely been doing some listening in that community and started to incorporate what we've heard.
Thank you, Jessica. That was a wonderful presentation. So our final speaker is Katie Howe. We've been hearing a little bit about her throughout the sessions from yesterday and from the plenary, but Katie serves as our Cystic Fibrosis Foundation Clinical Trial Navigator. And prior to this, she was a clinical research coordinator at Baylor, and she was a manager of the at UNC. At both centers, she was involved in quality improvement work, as well as at the CFF and TDN national committees. Katie holds a bachelor's degree in nutritional sciences from Michigan State University and a master's in human nutrition from Winthrop. Is that right? Is that how I said it? Winthrop University, and currently resides in Raleigh, North Carolina. So let's welcome Katie.
Thank you, Sarah. I know it's a long morning session, so we will get moving. So I'm going to just briefly go over research awareness and engagement for the new population, or for new populations in participating in research. As Sarah mentioned, I'm the clinical trial navigator for the CF Foundation, and I have no disclosures. Since the clinical trial navigator role is relatively new, it's been about a year, and I know that there are many new research coordinators every single year that come to conference. I'm just going to give you a brief overview of what the role entails.
And so really it's to facilitate community members' awareness of clinical trials, improve health literacy, address general questions regarding clinical trial participation, and assist with site-to-site referrals. You're going to see 2 QR codes. The top one is in English and the bottom one is in Spanish. And so there are a few ways that you can actually get in touch with me, and people with CF can get in touch with me, community members. And it's via email at trialnavigator@cff.org. Or there's a submission form through cff.org as well as the Spanish CFF webpage. And those are the 2 QR codes that you see here. So they're both in English, the submission forms in English and in Spanish. And I also want to note that we do have Spanish services that are available. And so if somebody who is Spanish speaking comes to me, or if you send anyone to me that wants to know more about clinical research, we use the Compass bilingual case managers. And so they are a little bit more aware of CF and what's entailed in CF research. So it's a very good starting place. I want to give you some examples of the information that I'm providing people, because I want you to know that it's not just a resource for people with CF and caregivers, but this is also a resource for you and care team members. So when it comes to people with CF and caregivers, a lot of what they're requesting is clinical trial logistics, an overview of the finder, an overview of the pipeline, knowing what's coming in the next 6 months to a year, specific clinical trial participation, and then research site contact information. So if somebody comes to me, naturally, they submit a submission form, they find what research is going on in their region or at their site, and they want to be connected with the research site staff, I can facilitate that process. And if it's at a site that's not at their care center, I can make sure that the research team, the care team, and the patient or person interested in participating all are in one loop on communication, which is very imperative when it comes to participating in research that's not at your care center. For some examples from our Cs and care team members, and again, I just want to emphasize that this is also a resource for you. Going over clinical trial basics and resources, going over the clinical trial finder, the referral toolkit that is on the hub now, not necessarily just on CFCRNet. Going over SMART reports, this is really big for care team members when it comes to engaging patients in clinic who may be eligible for certain trials. Going through regional cooperative resources, and then clinical trial navigation for patients in clinic. So I know a lot of people are kind of like, what are people asking her and what can she do? So just to give you a few examples, this is what people are asking and the information they're wanting from both the patient side, caregiver side, research team side, and care team members. So we've heard about bringing awareness and research engagement to the non-English speaking population, the pediatric population, and health equity and inclusivity when it comes to hard to reach populations. I'd like to take this last section to really dive into and discuss how we can use these lessons to better our engagement for all people living with CF. So a few things to consider when looking at clinical trial knowledge of new populations. We can't assume knowledge. I think this is something that is good across the board. We cannot assume knowledge in any aspect of care or research. Barriers to health and research is sometimes simply information. We need to bring the facts and compassion, and we really need to take the time to talk and actively listen. When it comes to engaging people with CF or caregivers of children with CF, whether it may be in clinic or over the phone, our time is generally limited. And I know I'm definitely guilty of this. Most of us, I'm sure, have a short script of what we plan on saying. We kind of go in with a mission, especially going into clinic when you're like dodging in between ancillary team members and you only have like maybe 2 minutes. So by show of hands, how many of us generally do this? I mentioned this just because as we move into an era of trials where we are engaging new populations, we can't assume that they have any clinical trial knowledge. Therefore, how we approach them, the information we provide, and the questions we ask will differ from person to person. Also, this is something that has helped me in the past as a research coordinator, taking the time to talk to your care team before you enter a room to engage somebody, whether it's research awareness or you know that they're eligible for a trial. It's a good way to understand what may be going on in their life, whether it is good or bad, to better prepare you for that conversation. And it's also a way just for you to kind of connect and start that rapport and building that trusting relationship. So on to clinical trial participation and mistrust. We have to provide space to discuss historical mistrust. We need to start with awareness and provide education around inclusive research, and we need to allow engagement with new populations to educate us. So we know that, yes, we may be kind of experts as research coordinators, but they are experts because they are the ones living with CF on a day-to-day basis. So not assuming knowledge, providing facts and information, taking the time to ask questions and actively listen can help build trusting relationships. This is a common thing that we've been hearing throughout conference so far, but it's advice that I received early on as a research coordinator from my CF care team social worker, and we have to meet people where they are. I think this is true for most aspects of life, and especially when it comes to health. There's a lot of historical mistrust in the medical and research community. Therefore, when engaging new populations for trial participation, we have to really take this into consideration. We must develop a solid foundation and meet people where they are in order to build a trusting relationship for them to consider clinical trial participation. Another PEP plug. So how do we go about this, and how do we have these conversations and build trusting relationships? I cannot emphasize PEP enough. I was on like the RC pilot program for PEP, and just out of show of hands, I know it's widely available and I know it's usually available at NACFC, but how many people have done PEP for research coordinators? Yes. If you haven't done it, there will be additional trainings after NACFC. That information will also be on the hub, so another plug for the hub. So if you are interested, you don't see where you can sign up for those sessions, please let one of us know. We can get you in contact and make sure that you're signed up for that. So I want to provide a quick example, and I was going to call her out if she was here, but unfortunately she couldn't make it to NACFC. So Dixie Durham is an RC out of Boise, Idaho, and although she wasn't able to join us today, she did give you permission to share this story. So when she engages with patients in clinic, the first question she asks is, so what do you, and she's very bubbly if you don't know Dixie. She's like, so what do you know about CF research? Followed by, what, if anything, what would you like to know about CF research? And she tells them, you know, it's okay if you don't know anything about research, and encourages them to ask questions if they're comfortable doing so. I really like this question because, one, it doesn't assume knowledge. Two, it opens the conversation for them to provide you with information they know, want, and need. And three, it allows you to actively listen without an agenda, which shows the patient you care and begins the first step in building a trusting relationship. Next, I just kind of want to go over a few patient engagement stories. It'll give you a little bit better idea of the type of people with CF that are coming to me and requesting information. So the first is a caregiver with an infant. This is a 7-month-old, class 1 mutation, not currently eligible for any trials. This is also their first child. She just wanted to be aware of what is in the pipeline, what resources are available now, so when the child does become eligible, she kind of knows the clinical trial logistics. It's this first step of, you know, providing that education, providing that health literacy, and we really discussed another community voice plug, but how community input drives CF research. So at this point, she can participate in focus groups and, you know, really start that early research engagement. So when her child does become eligible and she wants to take that next step, she can. Next is a caregiver of a pediatric patient or person with CF not eligible for modulator therapy. They are also not eligible in genetic therapy trials because of their age, but they really wanted education around clinical trial logistics and understanding their child's mutation. This is something I'm hearing a lot about is what does my mutation mean? What class does it fall into? And how does this translate to clinical trial participation and eligibility for clinical trials? So I think that's something that we really need to take into consideration as well when we're talking about participation and when we're approaching patients for clinical trial participation. This person, the child was actually referred, which is exciting. But again, we know that these conversations are very layered and there are multiple conversations, and I've had multiple conversations with both caregivers or individually. And so it's just another way of saying, you know, these conversations need to be had. It's very layered, and it's gonna take a little bit longer to engage some of these people with CF in clinical trials. The next is an adult with CF not eligible for modulator therapy and a new diagnosis. So this is an adult in their late 30s, new diagnosis. Not only are they new to CF, they're new to CF research. So it's a lot of information to take in all at one time. And it was really trying to understand what is the research landscape. They are eligible for genetic therapy trials, but if you think about learning about CF for the first time as a new diagnosis and then jumping into genetic therapy trials is a little overwhelming, but starting that conversation is always a good place, and having the resources available and the education. Again, the biggest theme of the last year of me being in this role has been health literacy, and which is fantastic, but really we know that these conversations are, a lot, especially when it comes to genetic therapy trials. And so having multiple conversations and starting that conversation, that initial conversation is always good. Similar with the next person, adult with CF, not eligible for modulator therapy, but very hesitant to participate in a phase 1, but very willing to participate in a phase 2. And so again, starting those conversations early, providing those resources, providing that education so they are comfortable coming to you as a research coordinator or coming to their provider care team and saying, I'm now ready to participate. The last, I want to go over just international people with CF. So I know with Carmen being in California and some other states, it's a little bit easier for international patients to try to engage with sites in those states. And I've had engagement from many countries at this point in time, but just indicating that, again, health literacy, a lot of people want to know the information. They want to know clinical trial logistics, what's going on at this point in time, what's going on in the future. Those resources are available, and we do have several contacts in different regions, different countries, where I can reach out to them and receive local resources and receive that local information, and then disseminate that back to the person that's asking for it. So I know that some coordinators will get emails from international people wanting to participate in trials. So if that's the case, I can always help provide local resources as well, just because we don't necessarily know what's going on in their country. So last, I know that Jessica briefly went over this, but this is a fantastic video. If you have not seen it, we're going to play it in just 1 minute, and that's how we will end the session. But this is an absolutely amazing video that came out in the spring of this year that the foundation put together regarding health equity, and this is not just about health equity in care, but also in research. And you know that it's going to take all of us to make this happen. We all have good days and bad days, but remembering the mission of the foundation and finding a cure for all with CF is what matters most. So I really encourage you, collaborate with your regional cooperatives so we can bring research awareness and engagement, as well as access to clinical trials to everyone with CF in an equitable manner. So I'm going to play this if I can.
It's critically important that we bring a health equity lens to everything that we do in cystic fibrosis. Back in 1938, Dr. Dorothy Anderson was the very first person to describe cystic fibrosis as a clinical entity. She actually described in the cases that she talked about a child who was Black and a child who was Hispanic. But unfortunately, those people were invisible to those who wrote the textbooks about cystic fibrosis. So it has been described repeatedly as a disease that occurs in white people. People who are Black, brown, they were left out of diagnosis, out of treatment and care for many years. So it's led to later diagnosis, which means people don't get care as early as they should. They are more likely to have severe infections and end up in the hospital a lot more, and they also are less likely to survive as long. These issues are built into the system. We have to be very intentional about knowing and acknowledging these differences, because we know that there are preventable causes to poor outcomes that we're seeing.
I grew up in foster care from, I would say, the age of 3 until the time that I aged out at around 19 years old. I had all the symptoms and signs of having cystic fibrosis since I was an infant. All throughout my time in foster care, none of my medical needs were ever addressed. To tell you the truth, I never even had a physical before. So the only time I seen a doctor was in the emergency room when something critical happened. And each time that I would go, they would just tell me that I had chronic bronchitis or severe asthma, and they would just give me some antibiotics and an inhaler and just send me home. I was diagnosed at 24 years old. When he first told me, he looked at me and he said, it must be somebody up in heaven who really likes you, because without any medication, without any treatment, you should have been dead by the time you turned 16. It's a miracle that you're here at 24. By the time I had my son at 32, I pretty much had a routine down as far as my CF was concerned. I remember when I gave birth and they put my son on my chest, he had this shallow breathing, and I knew automatically something was wrong. So the next day, my son, at the time that they were giving me the papers for discharge, he had threw up. And I remember saying to the nurse, could you give me the pediatrician? You know, my son just threw up and it's green. And so I remember her just taking a tissue and wiping it up and go, Mommy, it's not a problem. It's normal. Babies spit up all the time. And I said, but it was green. I remember seeing in her face how offended she was. So as I'm signing the paper, my son spits up again. This time I said, please go get the pediatrician. I need him to see this. So she goes to wipe it up again, and I grabbed her arm and I said, no. Do not wipe it up. Get the pediatrician because I want him to see this. She goes, oh, Mommy, it's normal. Okay. So she goes and gets the pediatrician, and he comes in. He sees the green sticky-like substance. And as soon as he sees it, he grabs my son out of my hands. He's running down the corridor with my baby in arms, and come to find out that that green substance that my son was spitting up, that's a symptom of babies with CF. Had I went home and not advocated for my son, my baby wouldn't have made it.
Health equity occurs when everyone has fair and just opportunities to have optimal health outcomes. Health inequities lead to health disparities. There are health disparities in cystic fibrosis in diagnosis, care, clinical trials, and health outcomes. Health disparities are these poor outcomes that we're talking about that are preventable. For example, if someone is taught in medical school and throughout their career that a disease only occurs in people who are white, if a person who is Black or Hispanic presents to them with those symptoms, they don't have to be a racist to not diagnose that person correctly, because the system led to their inappropriate knowledge about what CF is and who it can occur in. We have to look at the systems that lead to these health inequities and thus the health disparities that we see in cystic fibrosis. The difference between equity and equality is making sure people have what they actually need. So if you think about, for example, a family going to watch a baseball game and there's a 6-foot fence there. If you give them equal ways of seeing over the fence, the man didn't actually need the box in the first place. The woman might actually now be able to see over the fence, but the child still can't. That's an equal solution to the problem. An equitable solution would be to give everybody what they actually need to see over the fence. What we really want to achieve is justice. So in healthcare, what we need to do is remove those systemic barriers, poverty, racism, remove those, and then everyone can achieve optimal health outcomes. Health inequity in CF has also impacted research in multiple ways. So for example, with the CFTR modulators like Trikafta, the mutations that were tested were based on mostly people who are white. And that's huge because people who were in the trials got to continue on the medication for years before it was approved. And therefore, people of color were disproportionately excluded from having early access to these medications. And even now, because mutations in people of color are more likely to be rare or understudied, they are less likely to qualify for these life-changing medications.
When I think of health inequity, I think of how even though I had all the signs, all the symptoms of having CF, I wasn't diagnosed mainly because I was African American and Latina. Had I been tested based on my symptoms alone, then I would have been diagnosed a lot earlier.
It's really important that we bring the health equity lens to every aspect that we take care of in CF. So when we're thinking about cure, when we're thinking about care, and when we're thinking about community, we want all of our treatments, all of our approaches to engaging people to consider the entire population of people with CF. We don't want it to be one person of color on a committee of 50 people, because that's not representative of what our greater population looks like. We need to bring those diverse perspectives to the table so that the person who is there is not thought of as the only voice on this one issue. We want every single person to be thinking about how can we make sure that outcomes in CF, that belonging in CF is something that every single person with CF feels.
I'm a part of a CF group that are people of color. And when you hear them say how sometimes they don't want to speak up for themselves because they don't want to come across as aggressive or as problematic. So sometimes they just won't say anything because they don't want that to affect the kind of services that they receive. That's unfortunate, because if other members of the community are able to speak up for themselves and have other people speak up for them on the same issues, then they should be able to as well without any fear. And so I would hope that other patients and families can see themselves through my story and my experiences.
What gives me hope for the future is that we're actually having these conversations, actually working to identify the source of health inequity in CF means that we'll actually be able to start to make interventions that make optimal health outcomes a reality for every single person with CF.
I'm hopeful because I do see the changes happening. When I go to my CF center, I don't just see a sea of white people, from the doctor to the nurses. I see the attempt of involving people of color in the conversation and understanding the dynamics of people's backgrounds and people's way of living and how CF plays a part in that. I see that there's a desire to know and to make a difference.
We as a CF community need to acknowledge these health inequities and define the problem that led to these health disparities. We need to address these issues for all people with CF so everyone has a chance to have the best possible outcomes.
Okay, we will open it up for questions. Thank you.
While everybody's thinking, I'll just ask one since I'm sitting up here. So what I'm hearing is that patients can reach out to you directly, or we can reach out to you as a tool to facilitate referrals.
Correct. Or if you have really pretty much anything, if you have someone, I know generally people are short on time, if you have someone that's interested in learning about clinical trials or a specific clinical trial, you can direct them to me as well. And then we can go back to you as the research site once they've learned more about whatever trial they may be interested in.
I don't see anything in the chat yet. Does anyone have any other questions for Katie?
I know it's a long session. I know you guys are ready to go.
We're like almost at the end, I promise.
I'll be around after, so if you want to come up to me, you can ask a question as well.
Good.